Yes, ma'am.
Okay. So very good evening to the 2018 batch of KMC. Greetings from me, who's 2000. I'm sorry, I'm a 1991 batch of KMC, and I'm Dr. Priyadarshini, Professor and Head of Microbiology from Chettinad Hospital and Research Institute. I have about 15 years of teaching experience. I did my MBBS in KMC, from KMC. I belong to the 91 batch. I completed my MD microbiology from MMC. I also got a PhD in microbiology from Chettinad. And it gives me great pleasure to connect with my alma mater after so many of these years. And I hope you are benefited by this talk. This first talk will be on hepatitis viruses. And actually, I wanted to take it in 2 separate classes so that you can understand well. In case you feel that these lectures are beneficial, we can continue. Okay. So with that, I think I will start my class because now we have gone to 7:35. And I'm very sorry for selecting this time because I work in Chettinad, it takes about 1 hour for me to come back. So 5 o'clock will not be a suitable time for me because that is the time I just come back home. So this gives me some time to relax and then continue with the work. Okay. So hepatitis is inflammation of the liver parenchyma. You all must be knowing that. And hepatitis or the viral hepatitis is only one of the etiological causes of this liver parenchymal inflammation. Okay. So you can get bacterial causes, viral causes, protozoa, right? Amoebic hepatitis you can get, fungal hepatitis. There can be so many other causes for hepatitis such as alcohol abuse, IV drug uses. Sometimes it can be drug induced, it could be hereditary, or sometimes we may not even know the causes of the hepatitis. So when you say hepatitis, it means that the whole liver parenchyma is inflamed. And when you say viral hepatitis, it is primary infection of the liver by any one of the heterogeneous group of hepatitis viruses. Okay. So when you say heterogeneous group, you're naming the viruses as hepatitis A, B, C, D, and all that, like you're learning your alphabet. But see, they all don't belong to the same families. Okay, they all belong to different taxonomical families. So, like bacteria you classify as Enterobacteriaceae, Vibrionaceae, like that. Here also different families are there. You have flavivirus, you have calicivirus, okay, hepatnavirus, like that. But they're all grouped under hepatitis viruses because they all have a common target organ, that is the liver. Okay. And what are the types of hepatitis viruses that we have discovered so far? This is actually in order of them being discovered. Okay. I'm sorry. So hepatitis A, B, C, D, E, and G. Okay. You can see that F is not there. Type F is actually a mutant of hepatitis B. They have discovered that it's a mutant of hepatitis B virus. So initially there was a hepatitis F virus, but now it has been removed. So now you have only hepatitis B mutant known as HBX. One small X is there next to hepatitis B. And so no hepatitis F. So you have 6 different types of hepatitis viruses. All of them are hepatotropic, meaning they have an affinity to go to the liver cells, and they all cause a similar clinical illness. So what do you see in hepatitis? What do you usually see in hepatitis? What are the clinical manifestations of hepatitis? Dr. Bhupesh, care to answer? Anybody? So what is the striking feature in hepatitis? Clinical presentation.
Jaundice.
Jaundice. Okay. So they all cause jaundice, elevation of liver enzymes. Okay. And but the severity of the jaundice will vary according to the type of hepatitis virus. Okay. So in the next slide that you're seeing, you see that I have made a table and we have fitted in all the different 6 types of viruses that we have studied. So you have hepatitis A. The mode of transmission is fecal-oral route. Okay. And hepatitis E also, the mode of fecal-oral route. So both those two are given in a different color. Okay. That is, both of them are same route. And these 2 viruses are very similar, hepatitis A and E virus. Okay. But you see, the causative agent belongs to the family Picornaviridae. Hepatitis A virus belongs to Picornaviridae. Actually, picorna comes from pico, which means which is very small, and then RNA. So it's a pico RNA viridae. Okay, and this virus does not cause any chronic liver disease, and there is an inactivated viral vaccine available for hepatitis A. So you have a vaccine, you have taken the vaccine for hepatitis A, you are safe. The next virus is hepatitis B virus. The mode of transmission is parenteral, or it's a sexually transmitted route. Congenital transmission also occurs. It belongs to the Hepatnaviridae family, and this can cause chronic liver disease. And for hepatitis B also, you know that a vaccine is available, and all of us would have been administered this vaccine when we are entering into the medical school. Okay. Then the third group is hepatitis C virus, and this is also transmitted by the parenteral route. Here it belongs to the filovirus family, and this also causes chronic liver disease, and there is no vaccine for hepatitis C virus. So as you can see, B and C are very common nowadays in most of the countries, but for B at least you have a vaccine available, so you can get protected, whereas for C, the same problem of chronic liver disease is there, leading on to cirrhosis as well as hepatocellular carcinoma, but no vaccine is available. So it's more dangerous. Okay. And then you have hepatitis D virus. It's also known as Delta virus or a defective virus. This is also transmitted by the parenteral route. And here also, what is the beauty of this virus is that the hepatitis B vaccine also protects against hepatitis D virus. Okay. Then hepatitis E, I already told you, it's transmitted through the fecal-oral route. The family is calicivirus. Okay. And this also does not cause any chronic liver disease, and there is no vaccine available. And then finally, hepatitis G virus. This was the virus to be last discovered in the 1990s, transmitted by the parenteral route. They have suggested that this also causes chronic liver disease, but there's no actual proof to say so by means of, histopathological studies, that is a liver biopsy, or by means of liver enzymes. Okay, they don't show much elevation or much changes in the liver parenchyma. And then this also belongs to the flavivirus. Okay, flavivirus family, and here also no vaccine is available. So this is the classification of the hepatitis viruses. As mentioned earlier, each one of these viruses, all of the causes hepatitis. They all belong to different taxonomical families, but they all cause a similar clinical illness. That is why they are all grouped under hepatitis virus. In addition to these hepatitis viruses, there can be other viruses which affect the liver, which can cause hepatitis, like your cytomegalovirus, CMV, Epstein-Barr virus, herpes simplex virus. These three come under the family of herpes viruses. Okay. Then you also have a yellow fever virus, a rubella virus, and other enteroviruses. So I hope it's clear so far. So we saw the definition of viral hepatitis. Then we saw why it is named as hepatitis viruses and how many of these hepatitis viruses are there. And we saw a quick table on how these viruses are classified and how they are transmitted and for which the vaccine is available. In addition to it, we also saw the other viruses which can cause hepatitis. Okay. So my idea is in today's lecture, I will talk about hepatitis A virus, E virus, and C virus. Okay. Because A and E are very similar in their structure as well as in the clinical presentation. I want to group both together so that you can compare and contrast. After that, I will finish hepatitis C virus. That is for today's class. Then next class, we will do B and D alone. Okay, because B is a very important topic for you, both in your practice as well as for your examinations. You can expect an essay question from hepatitis B, so I'd like to cover that separately. Okay, so saying, I'll go to the first virus, hepatitis A virus. It is also known as HAV in short, hepatitis A virus. Okay, and now a little more detailed study of this hepatitis A virus. We already saw that it belongs to the picornaviridae. Okay, so pico RNA viridae. So namely it is there. It is an RNA virus. Okay, and the genus is called as hepatovirus. Earlier it was known as enterovirus type 72, the same family as the poliovirus. But because its clinical presentation is different from all the enteroviruses, because it causes hepatitis and jaundice and all that, it has been classified under the genus of hepatovirus. A separate genus has been assigned for this. And hepatitis virus has got only one serotype, meaning only one antigenic type of this virus is present throughout the world. So if you get one attack of hepatitis A, you develop lifelong immunity. Okay, unlike you're seeing this COVID, isn't it? You're seeing mutations in the virus, and then you're seeing that it keeps changing its structure. So as soon as you develop immunity, what happens? It changes its structure, and then you're facing a new virus altogether. So your old immunity does not have any effect. You're more prone for reinfection. All that is because your immunity cannot recognize the new virus. But you needn't worry about hepatitis A virus because it's quite, stable. Only one serotype is present. And just keep in mind that it's a very small virus, already told you. It's only 27 nanometers in diameter. And also remember that very small viruses are non-enveloped. So if you see hepatitis A virus, a very tiny virus, and it doesn't have an envelope, and it's an RNA virus. And among all these 6 hepatitis viruses, this is the only virus which can be cultivated in vitro. When you say in vitro, it means you're growing it in the lab. In vivo means within the human body. Okay. Coming to the transmission of hepatitis A virus, it's only a human infection. Okay, that means no animal to human transmission, no animal reservoirs. But in the lab, experimentally, monkeys have been infected by this virus. Okay, it gets transmitted by the fecal-oral route, right? Already mentioned. So either we get the infection by eating, that is ingestion of contaminated food, or drinking water, which is infected. And another very common method is eating raw shellfish, because these shellfish have the ability to concentrate the virus within their flesh several fold. So when you eat raw fish, which is not cooked properly, there's a chance that the virus is not inactivated, so you can get the infection. It can also spread from these food handlers, just like so many other infections, bacterial infections like typhoid and all that. It can spread by close personal contact. This you have to be careful, because suppose you give care for a hepatitis A virus patient in your family, when you come in contact with their secretions or vomitus or any fluid, there's a chance that you will get the infection. Parental transmission is very rare. It almost does not occur. And there is no transplacental transmission. That is no transmission from the mother to the baby. Okay. What are the risk factors for infection? It leads to what are the factors that will make you prone to get this hepatitis A infection? So one is overcrowding, right? It's a fecal-orally transmitted infection which is associated with poor hygiene and sanitation. So these are risk factors. Then people who are staying in the house, the same house as the patients or any infected person. Institutional spread. So you can get infection from one person to another by means of mental asylums. In mental asylums or in jails, people where they are crowded together, you can expect a sudden outbreak. And people, especially kids who are living in areas where there is increased prevalence of hepatitis A infection, people traveling to countries which are developed countries to countries where hepatitis A is common, like India. And the epidemiology of this virus is very similar to that of polio. I told you, isn't it? It belongs to the same family. And in developing countries, the infection occurs by childhood. Okay. But in developed countries, more towards the adolescent and adult age group. So there is an upward shift in the age. And this infection can occur as sporadic cases. That means you have a few cases occurring in an area continuously throughout the year. Sometimes you can get epidemics. This usually occurs during heavy rains, when you can get contamination of your drinking water, isn't it? The roads get flooded, and then you have these pipelines getting contaminated. So it can occur as epidemics during that time. So epidemic means you have increased incidence of a particular disease in a particular area in excess of what you expected to occur. Okay. So regarding the pathogenesis, so now we saw how it has entered. So it enters through the fecal-oral route, contaminated food and water, and shellfish. Okay, they concentrate the virus in their body. And once it goes inside the gastrointestinal tract, it multiplies in the intestinal epithelium. And from there, it can go to the liver, okay, by means of blood spread. So from the intestinal epithelium, it goes into the liver and it multiplies in the liver, and then it keeps getting shed in the stool, that is in the feces, during the late incubation period and during the prodromal illness. And once the jaundice sets in, it will stop. Okay, and you have a brief viremia during the pre-icteric phase, and so they're just like the virus being shed in the feces. At the same time, you have a brief viremia also, and then it stops once the jaundice sets in. And one important thing you'll have to know is in hepatitis A, you don't have any chronic viremia or a chronic carrier state. I hope I'm clear so far. So we saw about the mode of transmission, the risk factors, the epidemiology, then we saw the pathogenesis, okay? Through the intestinal epithelium, going to the liver, multiplying in the liver, it's shed into the intestinal tract, so it's shed in the feces. At the same time, you have a viremia also. Both these things stop when the jaundice sets in, okay? And see the incubation period, you will have to remember like a table. It varies for each one of these viruses. I'll tell you an easy way to remember. So this range is 15 to 50 days. Remember that for hepatitis A virus, 15 to 50 days. Average is around 30 days, that is 1 month. Majority of the people are asymptomatic. That means you'll be having the infection, but you will not produce any signs and symptoms of the disease, okay? Or you might go off, escape with a mild fever. Overt illness, that is with all the characteristic clinical features, can be seen in 5% of the patients. And just like you're seeing in COVID, this hepatitis A is usually, most of the viral infections, if you see, they're milder in children, okay? And so these are the main clinical features and the incubation period. You have to know the incubation period because that is one way of differentiating between the different types of hepatitis. Okay, so here you are seeing a picture where the sclera is jaundiced. Okay, this is a picture of a jaundiced sclera. And the clinical disease, you can divide it into two stages. So one is known as the prodromal stage or the pre-icteric stage. The other stage is known as the icteric stage. So when you say prodrome, means it is just before getting the actual illness, or that is why it's known as a pre-icteric stage. This you can see in many viral infections like chickenpox also. Already you'll be having, slight, fever, or tiredness will be there. And then slowly, because the liver is getting affected, the person develops abdominal pain, tenderness in the area of the liver. Then there's loss of appetite because the GIT is involved, isn't it? The liver is an important part of your GIT. So that is known as anorexia. Then the person develops nausea and vomiting. Okay. So it starts with fever, abdominal pain and vomiting. And mind you, the vomiting will be very severe. These people will not be able to tolerate smoking. The smoking will trigger the episode of vomiting. Okay. And then finally, when jaundice sets in, all these above symptoms will subside. The previously mentioned symptoms, they subside. And then the person recovers slowly over 1 month. You have to give them rest for 1 month, okay? You don't have to give any specific antivirals or anything, but it will take 1 month for the jaundice as well as the elevated liver enzymes to come down, okay? So what are the complications of hepatitis A? There is one condition known as fulminant hepatitis. Fulminant means very severe hepatitis. It can lead to death, but in a very small percentage of the patients. So that it's very rare to see somebody dying of hepatitis A. So in hepatitis A, you get the infection, you struggle for 4 weeks to 5 weeks, and then you are completely cured, and you will not have any chronic sequelae, and you are having lifelong immunity. So you suffer only for those 4 weeks, okay? And so that is the thing about hepatitis A, the clinical manifestations. Now we go on to the lab diagnosis. So lab diagnosis is, see, you have to demonstrate the virus or the viral antigen or the antibody to the virus, okay? So immediately during the infection, if you want to demonstrate the infection, if you want to confirm that it is hepatitis A, you have to try to show the virus or the viral antigen, because antibody will only tell you it is a recent infection, but it will not tell you immediately that you are having an infection now, unless of course you can demonstrate that your antibody titer is increasing, okay? So what is the mechanism or the type of study used is, it's known as immunoelectron microscopy, IEM. This is done in the fecal extracts during the late incubation period and during the pre-icteric phase. But how will you know during the late incubation period and pre-icteric phase that it is hepatitis? You can think that it is any virus viral infection. So this is only by, this is only by, not everybody will have clinical suspicion of hepatitis at them. So this is more of a theoretical kind of a reasoning. So the usual diagnosis is by antibody demonstration. That means when it is known as a retrospective diagnosis. The person has already got hepatitis, and during the recovery period, you try to demonstrate the presence of antibodies. You do an IgM ELISA. Okay, you do an ELISA or a CLIA. So IgM appears in the serum during the late incubation period itself. It peaks by 2 to 3 weeks, okay, of the illness, and then it disappears in 3 to 4 months. Okay, after 3 to 4 months, you will see there will be a reducing amount of IgM in the blood. But IgG, even though it peaks almost at the same time or little later than that, the antibody will persist lifelong, and that is only responsible for giving you that lifelong immunity. And acute infection, so you want to know a patient has just had a recent infection or an acute infection, you know that you have to do an IgM ELISA. And past infection, you want to know whether he is immune to hepatitis, you look for IgG antibodies. Similarly, when you want to know whether your vaccination is effective, again you will look for IgG antibodies. Okay. So this is it about hepatitis A, and you can see that there is no cross immunity between hepatitis A and other hepatitis viruses. Meaning, if you develop immunity to hepatitis A, you're immune only to hepatitis A virus and not the other 5. Okay. To hepatitis A, you have a lifelong immunity. So that is one thing you need to know. And there's one more good news about hepatitis A is that it is preventable. How it is preventable? They undertake some general measures as well as some specific measures. General, you all will be thorough, right? Proper cooking of food, that's there for any waterborne or foodborne infection. Boiling your drinking water, okay, which at 100 degrees, if you keep it at 1 minute, the virus gets inactivated. Chlorinating your drinking water, the concentration is 1 part per million. You keep for 30 minutes, that also, gives you, inactivates the virus. And another difficult thing to be done is, prevention of fecal contamination of this drinking water as well as the food. So suppose you want to go to specific prophylaxis, that is, this is all general, this will protect me against any waterborne or foodborne infection. So what will you do for specific prophylaxis? Either you can look for a passive immunity or an active immunity. So what is passive? It's something like a ready-made immunity. Okay, your body does not have time. You're already exposed to the infection. We don't have time to make antibodies. I have to protect myself immediately. So what will I do? I will give myself immunoglobulins. So pooled normal human immunoglobulin. Okay, the percentage is 16%, and you give 0.2 ml per kg body weight. You give it by an intramuscular route. You give it just during the early incubation period or before getting exposed to any patient. If you're, some relative, or you're going to get patient, it, or you're going to work in an infectious disease ward, then during that time you can give yourself the infection. Here you see means it will not prevent the infection, meaning when you're exposed to hepatitis A, you will get the infection. It will not prevent the excretion of the virus from your system, but what you do is it will reduce the severity of the disease that you're going to get. And the second hepatitis prophylaxis is specific prophylaxis. Here, this is known as active immunity. This is what you're doing. You're stimulating our body's immune system by giving a vaccine. Vaccine is nothing but this hepatitis A virus. I told you it is the only virus which can be grown in the lab. So it is grown in HDCC, that is human diploid cell cultures, and then it is inactivated by using formalin, and it is conjugated by using alum. Why do we use alum? To increase the antigenicity of the viral component. Okay, and we give it as 2 intramuscular injections, and then you see the protection will start beginning about 1 month after infection. So you have to wait for 1 month to get yourself to protected, or you want to check whether you've got protective antibodies, and they say that the immunity lasts for 10 to 20 years. Okay, so is it clear? Do people understand?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
Anybody else? Are you people following? You're able to follow?
Yes,
Abhinaya,
ma'am.
Abhinaya, Aditi, Akshaya.
Yes, ma'am.
Yes, ma'am.
Okay.
Yes, ma'am.
You're able to understand? Okay. Shall I go to the next virus? Hepatitis E virus. Okay. See, this will be very similar to A. That is why I grouped it along with hepatitis A virus. Okay. So here it is known as HEV, hepatitis E virus. And just one small introduction for this virus. Just before this name hepatitis E virus was given for this or allotted for this virus, earlier there were two groups of viruses only known. Okay, so one group is hepatitis A virus, which is all the fecal-orally transmitted viruses, and another group is known as serum hepatitis, all the hepatitis B virus. Okay, transmitted by the parenteral and the sexual route. Later on, they found out, in addition to these two, there are so many other viral infections. So they named them as non-A, non-B hepatitis viruses. Okay, and among these non-A, non-B hepatitis viruses, enterically transmitted, that is fecal-orally transmitted, or epidemic non-A, non-B hepatitis only is later called as hepatitis E virus. Okay. So bulk of A non-B hepatitis is by means of this enteric virus, which is now known as enterically transmitted virus, which is now known as hepatitis E virus. Okay. And in India, that is our country, we will be having same two kinds of cases, sporadic cases and epidemic cases. And this virus also resembles hepatitis A virus very much, both in the virological aspect as well as serological aspect. But the only way in which you differentiate is you don't have a serological evidence of hepatitis A virus infection, meaning the patient will be negative for IgM or IgG anti-HAV. Okay, but still they'll be having all the clinical signs and symptoms of jaundice and viral hepatitis. At this time, you will be suspecting that it is hepatitis E virus. Okay, and this virus you cannot cultivate it in the lab, but its genome has been studied extensively and it has been cloned. So now coming to the morphology and other structures, just try to bring to your mind or try to recollect about hepatitis A virus. Then you can compare and study two viruses. See, this belongs to the family of Calliciviridae, whereas hepatitis A belongs to the family picornavirus, isn't it? And that was hepatovirus, and this is herpes virus, hepatitis E virus. So herpes virus belonging to the family Calliciviridae. And the similarity here is this is also a spherical virus, and this is also a non-enveloped virus and a very small virus. Just keep in mind that very tiny viruses are non-enveloped. I already told you. And that hepatite 1 nanometers, this one is 32 to 34 nanometers in diameter. Okay. Another feature is it's an RNA virus. It's a single strand genome. And on the surface of the virus, you'll see in this picture, you will be seeing projections, that is known as spikes, and indentations, that means depressions. Okay, on the surface of this virus, it is not enveloped, and this virus has not been cultivated in the lab. This is the electron microscopic study from the feces with hepatitis E virus. Okay, incubation period is, so that one was 50 days. Hepatitis E is 15 to 60 days. Okay, slightly more prolonged incubation period. In hepatitis A, you saw that usually children are affected. And in developed countries, the higher age group people are affected. Here it is young to middle-aged adults getting affected. Again, there also most of it is asymptomatic infection. Here also very mild self-limiting illness. Sometimes the severity will increase with age. Okay. Case fatality is also very low. It is only 1 to 3%. But one thing you should know is in pregnant women, especially in the third trimester of pregnancy, the mortality due to this hepatitis E virus is very high. It is known as a fatal fulminant hepatitis. And this is an MCQ which everybody, all the exams, they will ask you. Okay. So fulminant fatal hepatitis in pregnancy is most likely caused by hepatitis E virus. The reason is not known, but the mortality rate is very high in the case of pregnant women who get infected with hepatitis E virus. Okay. Here also there is no chronic state or there's no chronic sequelae, meaning liver damage leading to cirrhosis and hepatocellular carcinoma is not there. Okay. How do you do a lab diagnosis? You do an immunoelectron microscopy. Okay. Either specimen will be feces or the bile from the patients during the late incubation period or acute phase of the illness. But as I told you earlier, during that time, the level of clinical suspicion will be very low. So here also it is a retrospective diagnosis. You look and demonstrate IgM antibodies and IgG antibodies by using ELISA. And here what you use as antigen is the recombinant peptide and synthetic antigens. Okay, so this is about hepatitis E lab diagnosis. And again, the general measures of prevention are the same. So proper hygiene and sanitation, proper drinking water, either boiled water or chlorinated, proper cooking of food. Okay, avoiding raw food and all that. And there is no vaccine available for hepatitis E as of now, and we don't give any antiviral drugs also to treat hepatitis E as of now. Okay, so same thing, no antiviral drugs, as that is similar to hepatitis. But you see, for hepatitis A, you had a vaccine, you had immunoglobulins, whereas for this, it's not available. Okay, so in this, by now we have compared and contrasted two viruses. Both of them are feco-orally transmitted. The similarities are that both are RNA viruses, both are non-enveloped viruses which are feco-orally transmitted. Okay, the incubation period for hepatitis A is 15 to 50 days, whereas for hepatitis E is 15 to 60 days. Okay, and hepatitis A is very common in childhood but asymptomatic. This hepatitis E is slightly older children and adults. Okay, and hepatitis E only causes this fulminant fatal hepatitis in pregnant ladies, where the mortality rate can go very high. Okay, and both of them do not have any chronic carrier state or any cirrhosis or chronic sequelae leading to cancer or cirrhosis of the liver. And once you suffer from this infection, you get immunity. But for hepatitis A, there is a vaccine available. For hepatitis E, there is no vaccine available. General measures is also the same for both these viruses. Okay. Now we'll be going on to another virus, which is known as hepatitis C virus. And this virus is slightly different from the others in that it is parentally transmitted. Okay. So there is a parental method of transmission for this virus. And you remember C. C stands for chronic infection. C stands for carrier state. C stands for cirrhosis. And C stands for cancer. So you remember these 4 C's, you can write a short note on your hepatitis C virus. Okay. So cirrhosis, cancer, carrier state, and what is the other C? Chronic infection. Okay. So I already talked to you about this non-A, non-B hepatitis when I was mentioning about hepatitis E virus. So similarly, there is a parentally transmitted virus known as hepatitis C, which was identified and put under, initially it was non-A, non-B virus. Now it is put as hepatitis C virus or classified as hepatitis C virus. And this is a very common cause of post-transfusion hepatitis. Okay. And it's very similar to hepatitis B virus in clinical and epidemiological features. And it is occurring throughout the world. And you have so many cases of this hepatitis C throughout the world. You have more than 200 million carriers. Okay. And the carrier rate can vary between geographical locations between 1 and 20%. Okay. So in some places, the carrier state can be 1% or it can be 5% or as high as 20%. And in India, you can get almost 12.5 million cases being present. And this infection occurs in humans only. Okay. So this hepatitis C is a parentally transmitted virus. Okay. Now coming on to a little bit about the morphology of the virus. Here the family is flavivirus. Okay. Initially we saw picornavirus, then we saw calicivirus. Now today another family is flavivirus. It's the same as your dengue virus. Okay. Genus is Hepatitis C virus, hepatitis C virus or Hepatitis C virus. And this virus, however, is slightly bigger in size. Okay, till now we were seeing something like 20 nanometers and 30 nanometers. This one is a little bigger. It's 50 to 60 nanometers. So bigger viruses, you can expect them to have an envelope. So this is an enveloped virus, and it has got a single-stranded RNA. As you see, it looks like a snake. So this is also an RNA virus. So today, all the 3 viruses that we have seen so far are RNA virus. Just give me a minute. And this, and you can see the glycoprotein spikes on the surface of this virus. Okay. But here the difference is, in the case of hepatitis C virus, it is antigenically diverse, meaning throughout the world you can get different types of this virus occurring. So 6 different types of this virus are there throughout the world. So they are known as genotypes. So it shows some amount of antigenic and genetic diversity. So that's a problem when it comes to making a vaccine. And this virus cannot be cultivated in the lab. So similar to your hepatitis E virus, but however, they know exactly what is the structure of the genome. So they have cloned it in E. coli. Okay. So that is the basic morphology of this hepatitis C virus. And then some important points to remember is that who are the people at risk of getting hepatitis C? So people who are undergoing a transplant from an infected donor, who have received a blood transfusion, you have not screened the person properly for hepatitis C, so they might get the infection. IV drug users, patients on hemodialysis, okay, accidental injuries with needles and sharps. So we belong to this category. The healthcare workers, the doctors, the nurses, the technicians, the housekeeping personnel, all of them can get infected. And hepatitis C is more infectious than HIV. 10 times more infectious than HIV, and hepatitis B is 10 times more infectious than your hepatitis C. Okay, and people having multiple sexual partners or a baby born to a HCV infected mother, all these people are at increased risk of developing hepatitis C infection. And regarding the source of infection, see, you don't get to see an overt case of hepatitis C. Always it's a carrier. So the source of infection is a carrier, and you see the incubation period. Now you're keeping that 15 constant. It's 15 to 160 days. So first one was 15 to 50, then it became 15 to 60. Now it is 15 to 160 days. And see the statistics here, 30 to 40% of the cases are very mild to an anectic illness. Overt jaundice, that means presenting as jaundice, you will see it only in 5% of the cases. But if you see chronic hepatitis, you will see in 50 to 80% of the people who are infected with this virus. So directly, you won't have any acute presentation, you won't have any jaundice, but the person will develop chronic hepatitis. And then it can go on to cirrhosis and hepatocellular carcinoma. This is the dangerous part. Right from cirrhosis onwards itself, you know that the liver function is gone. The patient's life is compromised. More chance of mortality is there. And persistent infection, you will see in 85 to 100% of the patients. So many of them will get infected. Okay. So how do you do a lab diagnosis? For hepatitis C, we try to usually detect the antibodies to this hepatitis C virus. And in case the antibodies become positive, then we try to look for the viral RNA. Okay. So usually we look for these antibodies by ELISA, but you can also use chemiluminescence immunoassay. Okay. And several generations of ELISA is there. That is beyond the scope of this talk. Maybe another day we can discuss. And third generation ELISA usually uses a non-structural protein. Okay. Targets the non-structural protein region. So the antigen is usually coated on your ELISA wells, and then you try to detect the antibodies in the patient. Okay. And then another technique is HCV RNA detection, which is a very sensitive and a specific method. And then another thing is HCV antigen detection. So either you can detect the antibodies to HCV, or you can detect the viral RNA, or you can detect the viral antigen. Okay. RNA is you can do the regular PCR, but usually diagnostic laboratories go for real-time PCR. Okay. And regarding the treatment for hepatitis C infection, it is usually a combination of interferons with ribavirin. Okay, it gives you a better response than only using these interferons. Okay, because you are going to look at somebody with a chronic infection, so you are looking at a long-term treatment, follow up with the gastroenterologist, and so many other problems are there. Okay, And the prevention of hepatitis C, general prophylaxis is C. It is a parentally or a sexually transmitted infection. So you have to screen your donors properly, both the blood donors, organ donors, and tissue donors. Initially, for screening of the blood from a donor, we just thought that detection of antibodies is enough. So we do an antibody to hepatitis B, we do an hepatitis C, then we do an antibody to HIV, and we try to look for hepatitis B surface antigen. But many labs now, we do a PCR to directly look for the RNA or the DNA of the virus in the patient's blood, because that proof of that, when it is positive, it means that the virus is there in the person's blood. So you're being 100% sure that the person will not develop you're not going to transfuse that into your recipient. And then high risk behavior modification. So that is avoiding these multiple sexual partners and all that. And being medical professionals, we have to be very careful and follow the proper rules while you're treating patients and dealing with blood and body fluids. That precautions, you have to be very careful. But there is no specific active or passive immunizing agent. Okay, so you don't have any immunoglobulins, you don't have any vaccine also for this virus. The last virus for today is hepatitis G virus. I told you, this was the last discovered virus also. That is why it is coming G in the alphabet. This is also similar to another virus known as GB virus. Okay, so hepatitis G includes both this hepatitis G virus and this GB virus. It is also belonging to the flavivirus family. It is a single-stranded RNA virus. Again, it cannot be cultured in the lab, but the genome can be cloned. And it has been found that it has a 27% homology or similarity with the hepatitis C virus. Okay, and this is also spreading by means of blood transfusion or by the parenteral route. Okay, and hepatitis G virus is a very rare cause of viral hepatitis, but still we have documented chronic infection and viremia, that is virus present in the blood, has been documented. But histological evidence of this liver damage and liver enzyme elevation is usually not so high. Okay, most of the infected people are asymptomatic, and this virus, a lot more study has to be done on this virus. So we are not even sure of the incubation period. Okay, and the risk groups are these IV drug users, patients on hemodialysis, people who are receiving organ transplants and transfusion, homosexuals. Okay, prevention, again, no specific prophylaxis. So this high risk behavior modification again, and proper screening of your donors. And currently, again, no serological test is also available for this. PCR, yes, some labs are doing, but again, PCR for this hepatitis G virus is not very widely available. Okay, so in today's class, we have discussed about 4 different viruses. Okay, all the 4 of the viruses are RNA viruses. 2 of them are been A and E are transmitted by the fecal-oral route. The other 2, C and G, are transmitted by the parental route or the sexual route. So I want you all to read up about these viruses, and if you are interested, we can have the next class maybe next week, and we can finish on hepatitis B virus. Okay, so that Dr. Bhupesh will be contacting me on that. And I also request you that I have given one link to Dr. Bhupesh. Okay, it has got a feedback form. So I just request you to, spend some time and fill up your feedback form so that we'll know exactly what you people require and we can modify according to. I hope that you have benefited by this lecture. So thank you very much. You have anything to say, Dr. Bhupesh? Can you just share
No.
the link with them?
Yes, ma'am.